Hello and welcome to your nutrition support module. I delivered the malnutrition module earlier in the year, so you might remember, but my name is Sheridan Hardy. I'm a dietitian that works in the hospital space, private practice, and I'm also doing a little bit of work with Queensland's Forensic and Mental Health Unit at the moment. If you have follow-up questions from this module today, I'm very happy for you to make contact through my Queensland Health email address, which I've listed down the bottom there. Or if you have any questions around placement or finding work in general, also very happy for you to reach out. So in relation to nutrition support, obviously there's different aspects of it. We have our food first, and then we move into our oral nutrition supplementation, like our nourishing fluids. Then you can step into enteral nutrition and or parenteral nutrition. Today, we're going to be focusing on that food first and oral nutrition supplementation. And I believe you'll have a module a bit later on that touches on enteral and parenteral nutrition. By the end of this module, we want to be looking at achieving these 5 learning goals. The first is to identify and consider patient factors affecting your intervention to help ensure that we're engaging in person-centered care. We want to understand the justification and importance of encouraging food first in nutrition support. And I'll touch on this, but this will come back to your confidence in explaining your rationale to other health professionals and also educating the patient. To have increased confidence in creating nutrition support interventions in malnutrition. Identify sources of relevant, high-quality, evidence-based resources to support patient education, and increased awareness of factors affecting oral nutrition supplement provision and sustainability. When I last spoke to you, it was for your malnutrition module, and we spent a lot of time focusing on assessment and diagnosis. Today, we're going to move into the intervention component, specifically focusing on food first and oral nutrition supplementation. Before we jump into specific interventions, I want to just take a little bit of time to talk through some factors to consider when looking at nutrition support. Firstly, it's important for us to reflect on why we encourage food first. It is the crux of what we do as dietitians, it's best practice, and having a strong understanding will help you confidently explain your rationale to other health professionals, but also empower your patient or client or consumer when you're giving education, being able to talk to it confidently and clearly so they can make an informed decision as to where they want to go with their care. Because it is such an important component, I would encourage you to spend a bit of time thinking about it. Like, I've got a bit of a list here, but I'm sure there's other things that you can think of, and potentially have a discussion with your peers and have a bit of a practice as to how you talk about this. So the first thing that my mind jumps to when I think about the benefits of starting with food first is the cost. Oral nutrition supplements, which I'm not too sure if you've touched on these before, but just as a quick background before I keep referring to them, they're a drink that is chock-a-block full of nutrition, energy, protein, some of them, all the micronutrients that your body needs as well, and you tend to buy them in a chemist. In the hospital, they are prescribed, so some people see them as a bit of a medication. At the pharmacy, they're quite expensive, and there is an opportunity for them to be subsidised if someone's eligible. But again, even then, they are quite costly. So if we can start with food first, which there's a bit more opportunity to figure out how to do that on a budget, it can be more cost effective for the patient. Working in the mental health and forensic facility has given me an appreciation for people stay in this facility, average length of stay is around 10 years, and any opportunity to try to decrease them feeling institutionalized, we will jump for. So if they are receiving a drink from the clinic and it's given out like medication, that's it can make them feel a bit more institutionalized and pull them further away from what their life will look like when they discharge back into the community. So we don't actually, and we don't have a big need to prescribe supplements very frequently. We try and start with food first as a way to just maintain some of that normality where possible. Similar to that, by optimizing food first, we are relying less on pharmaceutical products. And also, it is our physiologically normal process to get nutrition in. So, for example, when we eat food, it takes longer to break down, and that gives us that feeling of satiety. And that helps us make sure that we're spacing each meal with enough time in between. Whereas nourishing fluids, they don't follow the same process. With food, we get greater variety, decreased risk of flavor fatigue. And then as we get older, it actually could feel easier to rely on these nourishing fluids. But the less we engage in a skill, and those neurochemical pathways aren't used, they do start to deteriorate. So potentially, if we're not doing shopping and cooking and remembering how to store food, we do start to lose that ability. Similarly, skipping to that last point, maintaining swallowing and chewing capacity, if we're not using those muscles to chew our food and swallow our food, and we're relying on the nourishing fluids, we're going to start to lose that also. And finally, insoluble fiber, there's not a whole lot in the supplement, so you need to drink a lot to meet your requirements there. These last 2 points are actually based on what patients have reported to me. And part of that is they feel that their quality of life is improved when they're relying on food for nutrition rather than oral nutrition supplements. And also for people that do need to rely on oral nutrition supplements as their sole source of nutrition, a lot of people can find this quite isolating when they're in social situations and they go out for lunch with friends and everyone orders their meal and they'll sit there and have their supplement. So again, another reason that we use oral nutrition supplements if required, but we try to get the most out of food first. Indications for nutrition support. This slide might look familiar because it obviously was a part of the malnutrition module. Because if someone is not meeting their energy and protein requirements, then that is indication for nutrition support. So a part of that could be they're not getting in enough oral intake, and we spoke about some things that might result in that. For example, if people are feeling fuller, quicker, if they don't have access to food, or they have insufficient finances to be able to put towards food. So good to have a look back on that slide. In addition, we said that potentially someone has higher protein and energy requirements than normal, and this could be if they're in hospital fighting an infection, or if they are 2 weeks out of surgery. And there's examples of patient cohorts that might face these difficulties a bit more often. For example, someone that has cancer or hypothyroidism, they'll have increased requirements. So again, have a little squiz at that slide to refresh your memory. I remember learning about nutrition support in uni, and our lecturer posed the question, you have an elderly patient who isn't getting enough protein in at the moment, what foods do you talk to them about? And someone put up their hand and they said lean meat, and he pointed out it's likely they're going to have trouble with meat and chewing. Another person put their hand up and said legumes, and he pointed out that a lot of older adults can suffer intestinal discomfort with beans. And we're all sitting there in silence and thinking for a bit, and then he says custard, ice cream, cake, chocolate. So these are the foods that give us bang for our buck in terms of energy and protein. Hospitals have a nutrition cart, which is for people on a high energy, high protein menu. And it has these food items on it. And honestly, it is our savior when it comes to malnutrition in the hospital and makes up a big portion of our interventions. But I was also listening to a podcast last year, and it was an interview with a girl with cystic fibrosis. And she spoke about how the dietitian she worked with was encouraging her to eat, these high energy, high protein foods, cakes, custard, ice cream, because she had elevated requirements. And she disagreed with that because it also increased her risk of chronic conditions, and she just felt yucky eating these foods all the time. And so listening to that, it was interesting. It gave me perspective and reminded me to consider that, to just consider the patient as a whole, and we need to be thinking about and asking them what their health goals are. So I put this slide together to identify some considerations to help with your clinical reasoning when you're working with someone to increase the energy and protein in their diet. Again, there'd be more that I haven't thought of. So I encourage you, again, to chat to your peers and see what you can come up with just to help increase confidence for when you have these conversations, when you step into placement. And again, I hope I've put forward the idea that there's no wrong or right answer. It really just depends on the patient and what they're working towards. So for example, how long does this person need to focus on high energy, high protein? If they're a couple of days out of surgery, they've only got 2 weeks of elevated requirements, and they've got poor appetite after their body's been knocked around a bit. If they have cake, custard, whatever for 2 weeks, it's really not going to really exacerbate their risk of chronic disease. We need to weigh up the consequences of malnutrition versus higher salt, sugar, saturated fat intake, the availability of foods that they actually enjoy eating in this setting, because I know a lot of people come into hospital and the meals are different to what they're used to. So there is a lower variety of foods that they'll reach for. And as I kind of touched on with what my lecturer was talking about with older adults, there's nutrition impact symptoms that again decrease the variety of food available to the patient. So with dentition, they might be on an easy to chew diet, so they've got less options available, and the cakes and the custard and the ice cream, that's easier for them to eat. Same goes for texture modified diet, got decreased variety there, decreased choice, and also patients' motivation to eat. If they're in hospital or in the community and they aren't interested in food at the moment and they're losing weight, this could be a fantastic time to recommend foods that they really enjoy eating, like their ice cream or their chocolate or whatever it is that works for the patient. We need to also consider, if someone's on a thickened fluid, that any oral nutrition supplementation we're prescribing needs to align with what they've been prescribed by the speech pathologist. So I don't know if you guys have touched on thickened fluids and texture modified diets just yet. I'll give a very brief background in case you haven't. So when someone has trouble swallowing, so for example, the case study I'm going to talk to in the next module is someone who's had a stroke, and when oxygen isn't delivered to parts of the brain that coordinate swallowing, that part of the brain can die off. And so people can come out of having a stroke and the muscles in their mouth, they don't work as they previously did. And so when someone swallows, their mouth can't control whether it's going into their esophagus or their trachea. And if it's going down their trachea, it can go into their lungs. So this can happen for people with strokes. It can happen for older adults. It can happen if someone has a mental impairment, if they've come out of ICU. So this is part of the work that our speech pathologists do. They assess people's swallows and then prescribe a thickened fluids or texture modified diet accordingly. So with the thickened fluids, the thicker it is, the slower it moves down the throat, and the brain has more time to register it and gear the muscles accordingly to help ensure that it's going down the esophagus. And hopefully on your placement, you'll be able to try different thickened fluids, because it's a very interesting experience, and it's good for us to have a bit of an understanding around what our patients are going through when they have these. So if someone's on a moderately thick, if they're on moderately thick fluids, we don't want to be prescribing thin fluids, which is a lot of your supplements. In the hospital that I work at, we have pro drinks that have different thickness to them. So we'll be prescribing them rather than the oral nutrition supplements I'm going to go through today. So just something to consider. Alrighty, jumping into potential interventions for nutrition support. Firstly, we want to be ensuring that someone's actually getting sufficient protein at each meal. So in the hospital, this can be as easy as having the conversation with someone that they want to be ticking the protein component of the meal, so they're receiving it. But in the community, it's more around working on strategies and developing skills for someone to be able to identify what is a food rich in protein and how much do we want to be adding to the meal. So for example, in the mental health facility, I worked with a 27-year-old male who was admitted with paranoid schizophrenia the other day because he was complaining that he was really, really hungry and he wasn't getting a whole lot of variety in his diet. So when I spoke to him, he was mainly having 2-minute noodles, and he'd add vegetables to the broth. So part of my intervention was working through a resource with him to identify foods rich in protein and how to add it to meals. And he was also had a low budget to work with, so we ensured that the protein sources met his budget. The resource that I used, there's this fantastic one from Baker IDI that I come back to a lot called Plating It Up. And you can see down the bottom there, on the last page, it shows you what protein can look like in different meals. So if someone isn't just having their meat, potato, veg, which we know veg we want to take up half the plate, meat a quarter, potato or source of carbohydrates for the other quarter. When meals are more combined, like your stir fry or your salads, or you want to add salad to spaghetti without adding it to the sauce, it just talks you through different ways to do that. And being in a mental health facility and he has an intellectual impairment, I love that this resource is very visual as well. So just good to know that that one's out there. Another resource that I use more so with my patients in hospital, you can find it on Nemo. It's called the High Protein, High Energy Diet in Hospital. And it talks through some of these strategies. The first is, rather than eating 3 big meals a day, if someone has poor appetite and early satiety, where they're getting fuller quicker, they are more likely to be able to get more protein in if they're eating smaller, frequent, high energy, high protein meals. Again, for my patients in hospital, I'll talk to them about starting with the protein portion of the meal. So that can be obviously the meat, the beans, but also the dessert, because it tends to usually have custard or ice cream or cake with it. And then moving to the food rich in carbohydrates, and then prioritizing veggies last, just at this point when they are looking for more high energy, high protein. Another great strategy is if food is tricky to get down at that point. So for a lot of my patients with nausea, we'll actually move to nourishing fluids. And in the hospital, that can be Sustagen or flavored milk. But there's also a fantastic resource on Nemo, again, called Nourishing Fluids. And it's great for people in the community. It has different recipes in there. So I've just cut out this little part of the resource that talks through a high caloric thick shake that someone can create to help them sneak a bit more protein and energy into their diet. Fitting in with that strategy in the slide before of aiming for the 6 smaller high energy, high protein meals per day, Part of this can be through high energy, high protein snacks. So I've pulled this table from the Nemo Resource High Energy, High Protein diet. And again, it's fantastic. It goes through different food groups and what examples are of high energy, high protein foods. But I especially like this one as well, where in that left column, you can see some ideas there like your yogurt or custard, desserts, dried fruit or nuts, cheese or dips with biscuits and bread, eggs. And then on the right, it talks about little changes you can make to increase the energy and protein content there. So for example, with your yogurt, ensuring that we're choosing full cream varieties. And now we have the fantastic range of higher protein yogurts that are easy to increase the amount of protein in your diet. For example, even like veggie sticks, that's what a lot of people go to, but ensuring that we're dipping it into a high protein like nut butter spread or cream cheese. So it's got some fantastic ideas there. And what I do is I'll sit down with my patient, we'll go through the resource together, and we'll go through and highlight the ones that the patient thinks will work best for them. Food fortification is another great way to sneak in extra energy and protein. So we know that there's foods in the shopping centre that are fortified. So for example, your iodine in bread or your iron in Weet-Bix. We can fortify meals to increase the energy and protein in them quite easily. So for example, for our older adults that love their porridge, we'll encourage them to add cream to it. For other people where that's a little bit too heavy for their stomach, adding milk powder to their meals is a great way to sneak in some extra energy and protein. And again, it's on that same high energy, high protein diet resource that this little table's in, so you can work through that with your patient. If you and your patient have worked through those food first tips, or from the get-go you know that they're not going to be enough for the patient to meet their energy and protein requirements, we can start to consider oral nutrition supplements, which, as I touched on before, they're drinks that are jam-packed with energy and protein. There's lots of different options out there, so there's not really a one right supplement for different situations. It takes some clinical reasoning, it takes the patient's perspective to find an option that best suits the patient. So I'm going to chat through the different supplements and factors to consider when you're choosing oral nutrition supplements with your patient. Firstly, of course, we want to be taking into account what are their nutrition requirements, what is the nutrition content of the oral nutrition supplement, and what oral nutrition supplements do we want to use to help them meet their requirements. So when I've categorized these supplements, I've made the first one obviously powder ones that you can add to water or milk to make up the supplement. The second one is 1.5 kilocalorie per milliliter. And then the next one is 1.8 to 2.0 kilocalories per milliliter. So that last column are the ones that are going to give you the biggest bang for your buck in terms of energy and protein. You do get a little bit of a trade-off of taste when you go for those ones that are richer in nutrition. And it's partly because they have quite a metallic taste, and the companies compensate for this by making them quite sweet. So they're quite a concentrated, sweet, rich flavor. So it might be that someone can't actually get through one entire supplement that has high energy and protein requirements. So you're better off moving to a couple of the 1.5s if that's a bit more palatable for the patient. And we also want to be considering things like if someone has ascites and they need low sodium intake at the moment, we want to be looking at the sodium in the products to figure out which is most appropriate. And in this case, Resource fruit in the middle column down the bottom left, that's quite low in salt. And in the column just over, Nepro, the 1.8 kilocal per milliliter, it's something that we'd use for our patients that have renal failure or ascites. Cost is a big factor. You can, in hospital, like they have the supplements on hand, so obviously patients don't have to pay for it then. But when they're leaving hospital, if they're going to stay on the supplements, we need to consider how much is that going to cost the patient? Is there the possibility of it being subsidized to ensure that it's a sustainable strategy for the patient? As I touched on, the palatability changes for the different supplements. Most of the supplements are a creamy dairy flavour, but the resource fruit in that bottom left-hand corner, that's more a cordial consistency. So it's nice for patients to know that they've got both options there. And a lot of the supplements will come in multiple flavours. So for example, at the hospital I work at, the Ensure Plus in the middle column there, they've got chocolate or vanilla. In the resource fruit, they've got peach or wild berry flavour. So if patients aren't a big fan of one flavour, they can trial a couple, or they can go between the flavours to reduce the risk of flavour fatigue. We need to know the ingredients in the different supplements. If a patient has an intolerance or allergy, we need to be taking that into account. Also, if a patient has a fluid restriction and they're getting multiple supplements across the day, we need to discuss this with the patient that they need to be prioritizing those over, for example, their water. Or potentially for someone that is struggling to meet their fluid requirements and they've got multiple supplements during the day, this might actually be reducing their intake of overall fluid if they're not as palatable. So it's just these different factors that we need to consider and keep an eye on our patients. As I said, we need to consider whether speech pathology has put in a recommendation for fluid thickness, and we need to adhere to that accordingly. And as I touched on before, we need to consider if the patient's going to continue on this, what follow-up dietetic input are they going to receive? Because one, if they do get follow-up dietetic input, there's the potential for their supplements to be subsidized. But also, if someone is on multiple supplements a day and something in their situation changes and maybe they don't need as much of that nutrition anymore, we need to be reviewing that to ensure that it still meets their needs appropriately, because there are consequences of overnutrition in the long term as well. Considering the amount of volume that they're able to tolerate and the frequency, and again, the variety of flavors to reduce the risk of flavor fatigue. So, to help when you step into your placement, to wrap your head around the supplements, I would recommend completing a table like this one in the slide. Learning what supplements are available and popping them in the first column. What volume is the supplement, how many kilojoules, protein, the micronutrient content of specific ones that you're interested in, what's the cost, and then ask to try the supplement so that you can relate to the patient's experience, and you can talk to them about it when you're asking the patient to taste test them to figure out what they like, and just put some little notes in there so you remember. If you write the allergens, that will make it a little bit easier when you are prescribing supplements and someone's got an allergy, and then just understanding how the patient can access the supplement if they're no longer in hospital. I was recently sitting in an orientation for our new nurses at one of the facilities, and the speech pathologist was taking it. And one of the nurses spoke about how the texture modified diets, like the mince moist or the puree, looks disgusting, and the poor patients for having to have it. And the speech pathologist made a really good point of saying that if we make those comments in front of the patient, that can be very demoralizing for the patient, because really, like, if they're on the diet for a reason, because they're at risk of aspirating or choking, so they don't really have a choice in it if they want to look after their health. So what can we do to support these like patients or clients or consumers that are on texture modified diets? And it made me reflect a little bit. Like I said earlier on in the module, it can affect people's quality of life to be on these oral nutrition supplements, especially if it's their sole source of nutrition, or if they're on it in the long term. So I think it's good to have a little bit of a think about how to have those conversations with patients, because we don't want to be saying to them, oh, I know, look, they're really gross, but we've just got to do it. What's a different way that we can approach that to really support our patients? And so I've just had a bit of a brainstorm, and as any concern that a patient would share with us, we want to listen, acknowledge, and help them feel validated in their concerns. I think it's important for patients to really understand why we've recommended oral nutrition supplements and why they're having them, and that's empowering them with that education aspect of the intervention. I think it's a great idea to allow the patient to taste test the supplement before we pop it on their charts for multiple times a day, every day. So I'll usually take a couple of the supplements to the patient, and we'll sit there and I'll chat to them while they try a couple to see what they prefer most. And this also gives us the opportunity. So in the bottom right there, I've said brainstorm strategies to enhance palatability. If someone has a taste and they're like, oh, that's way too sweet, then we can talk through strategies. Okay, how could we make that a bit tastier? Could we ask the nursing staff to add a little bit of cold water to it to dilute it, and you can sip on it while you watch your TV show in the morning? Or just to the left of that little box where it says provide as MedPass, that's where we might give them just a little bit of the supplement multiple times across the day. So, for example, the 2.0 kilocalorie per milliliter one that I listed before, the Resource 2.0, it is quite thick, it is quite sweet. So rather than asking someone to drink that whole bottle in one sitting, I usually pop it down as 65 milliliters 3 times a day, morning, afternoon, evening. And that way they just have to drink a little bit of fluid rather than sitting there and going through the whole thing. So when the patient taste tests, it actually gives us an opportunity to work with them to figure out how we can make it a bit more palatable and bearable for them. And then it's aiming for that consistency. And I touched on that in the malnutrition module, but supportive nutrition care, ensuring that the supplement is close enough to the patient that they can get to it, that if they need assistance with opening it, the nursing staff know to do that. If the patient has dementia or they're very drowsy, they might need some prompting and encouragement to finish it. And also, as nursing staff maintain the fluid balance chart, which is pretty much just popping in how much of the supplement they've had, it allows us to come back and see if they were drinking it, did they enjoy it, and the consistency that they've been receiving it. And if the patient's if they're cognitively intact, then they can tell you this. But for a lot of our older adults, especially when they've got a lot of things going on in hospital and a lot of competing priorities, they might not remember that information. Okay, so just a bit of an introduction to the first steps of nutrition support today with that food first and the oral nutrition supplements. Obviously, if these weren't meeting energy and protein requirements, we might consider having the conversation with the treating team. Do we want to move to enteral nutrition? And in complex cases where the gut isn't working, then we might start to have conversations with the team around parenteral nutrition. But these will be discussed later in the semester in a different module. Thank you for tuning in today. And as I said at the start, if you have any questions, please feel free to reach out through my email. Very happy to have a chat. Thank you.